So, good evening, everyone. Okay. So, am I audible and visible to everyone? Today, this is the first session of the clinical physiology case discussion. So, seeing the pattern of NEET PG as well as FMG, as we know that integrated pattern is following nowadays. So, this is the first session of clinical based NEET PG. So, am I audible and visible to everyone? You can comment in the chat section. Then we will start discussion. Okay, Akshay. Okay. So, without further ado, let us start discussion of the first class. So, starting with the first question, I will read it for you. Good evening, good evening. Okay. So, good evening, everyone. So, question number one is a chest X-ray was done on a patient with left-sided heart failure. Okay. So, there is a left ventricular failure, and it showed that there is pulmonary edema. So, because of back pressure, there can be pulmonary edema, of course. So, which of the following can be expected in this patient? This is a very direct question, asking with the basic physiology. If you know that this is your heart and there is left side failure, okay, so your ventricle is not able to pump. So what will happen? As you know, this is giving back pressure to the pulmonary circulation as well. So what is expected in this patient? Decreased pulmonary artery pressure, normal vital capacity, increased pulmonary venous pressure, or increased arterial partial pressure of oxygen. So what is your, what do you think is the more appropriate option in this, in the left ventricular failure case? Okay. What do you think? Of course, this is back pressure. So what? This is a direct question. Is it decreased pulmonary artery pressure, or it is increased pulmonary venous pressure, or increased arterial partial pressure of oxygen? Ganesh, Dr. Ganesh, Andy. C. Increased pulmonary venous pressure. Okay, what about others? What others are thinking? If there is left ventricular failure, okay, tell me what will happen to preload? I will discuss everything about that. What will happen to preload? What is going to happen to preload? Preload will increase, isn't it? Preload will increase, number one. And when preload will increase, it will something like there will be increased stress on the left ventricular wall. There will be increased pressure on the left ventricular wall, and that can create a back pressure. So if there is back pressure, what is going to happen in the lung? It's very direct question, nothing new in that. You know the answer is C. It is increased pulmonary venous pressure. It is the characteristic of left side failure. It is the characteristic of left side failure. So one of the common cause of pulmonary edema. It is one of the most common cause of pulmonary edema is left sided heart failure. It is one of the most common cause. Okay. Good evening, Oras. Good evening. So there is a great increase. There is a great increase in the pulmonary venous pressure as well as pulmonary capillary pressure due to increase in the end diastolic pressure. So point number 2 to be noted over here is that there will be increase in diastolic volume. There will be increased stress on the left ventricular, as well as you can say preload is end diastolic volume. So preload is also increased. which is brought on by decreasing contractility of the myocardium. That is why positive inotropic agents are given, so that the pressure on the left ventricle can be decreased and your heart can be relaxed. And this edema, when there is pulmonary edema, okay, of course this will interfere with the gaseous exchange, and this vital capacity and arterial oxygen partial pressure will also reduce. So what will happen to these things? Okay, increase arterial partial pressure or decrease? If your lungs are not acting that properly because of pulmonary edema, what do you think, that partial pressure of oxygen in your alveoli is going to decrease or increase? If there is pulmonary edema, of course this will be less, and there will be increased AA gradient. If you remember, we have discussed about AA gradient, alveolar arterial oxygen gradient, that can also increase because of intrinsic lung disease. Okay, so all these things should be clear to you. Now this question, second question, is really very important. This question is very conceptual and very important. Let me see how many of you can attempt that. Okay, although this is a very basic simple question, if you attended my special classes in Unacademy, on Unacademy platform, we discussed a lot of things regarding respiratory physiology. So let me ask, a 30-year-old woman at 30 weeks of gestation goes to the obstetrician for a checkup, as she believes her breathing has been faster than usual. So respiratory rate is increased. So first thing is that in this question you can see respiratory rate is increase. Okay, based on the investigation values below, what can you say about her alveolar ventilation? So question is about alveolar ventilation. So I hope you remember every formula about alveolar ventilation which I have given in the theory class. What is alveolar ventilation? How can you calculate alveolar ventilation? What is dead space? What is minute ventilation? So you should have knowledge of everything. What is a minute ventilation? What is alveolar ventilation? What is the formula of dead space, and how to calculate dead space? Okay, so there are integration of three things together. So now let us see. PaO2 is 105, almost okay. Tidal volume you can say almost okay, 480 ml. Okay, PaCO2 is 30 mm of Hg. Respiratory rate is quite high. You can see here it is 30 deaths per minute. It is quite high. You can see here. Now respiratory quotient RQ is 0.8, pH is 7.47, bicarbonate is 20 milliequivalent per liter, hemoglobin is 12, anion gap is 12, PeCO2, it means CO2 in the expired air, CO2 in the expired air. Okay, tell me, what is your diagnosis? What is your final diagnosis? Then we will discuss the options. What do you think about the final diagnosis? Is it alkalosis or is it acidosis? And what, respiratory or metabolic? Good evening, Dr. Preeti. Good evening. Okay. So what do you think? Is it alkalosis or is it? Now this question is really a whole topic. If you want to discuss everything about respiration, everything can be discussed only on this single question. This is a very beautiful design question, and this is the latest pattern. It needs a lot of information. So number one thing is that alkalosis, of course, alkalosis. Now tell me, is it metabolic alkalosis or respiratory? So one thing you know, that this is Ravarma, acidosis. Why acidosis? You are, I mean, yes, Pranam, DP Singh, Pranam, Namaskar. So what do you think it is? Of course it is alkalosis, and you can see that PCO2 normally is how much? Normally PCO2 is 40 mm of Hg. So it is quite low. It is quite low. And bicarbonate is normally 24 milliequivalent, which is also low. So metabolic can be acidosis but not alkalosis. But because CO2 is less, so we have already discussed this point. Whenever CO2 is less, it might be respiratory alkalosis. It might be respiratory alkalosis. Point number one. So respiratory alkalosis means, I mean, hyperventilation or hypoventilation. when you are going to get respiratory alkalosis. Of course, there will be hyperventilation, which you can see in this patient. The presenting complaint of the patient is hyperventilation. So that might be a cause of respiratory alkalosis. No big deal in that. Okay. So after giving this clinical scenario, they want you to, test that your basics are clear or not. So let me first ask you what is the correct option, do you think? Then I will explain this question. Let me see how many of you are correct. A, B, C or D. First of all, let me see how many of you are correct. Then we will discuss question in detail. Alveolar ventilation in this patient exceeds her minute ventilation. Alveolar ventilation is greater than normal. Alveolar ventilation is inadequate due to rapid shallow breathing. Alveolar ventilation is less than her dead space ventilation. So you have to calculate alveolar ventilation in the normal. You have to calculate alveolar ventilation in the patient. You have to calculate dead space and dead space ventilation. So you need 4 data. Okay, what do you think is the answer? What do you think is the answer? It will take 1 minute at least. So I am giving you 60 seconds. I am giving you 60 seconds. It is enough for calculation if you know that. And I request everyone to please answer. If you interact, only then you can learn. Okay, C is alveolar ventilation is inadequate. Okay, due to rapid shallow breathing. Okay. A, alveolar ventilation exceeds her minute ventilation. Okay. Please everyone answer, don't hesitate to answer, because if you make mistake and then when you learn, you will never forget in your whole life. Mistakes are very important in your life, isn't it? Akshay Gupta, A, alveolar ventilation exceed her minute ventilation. Okay, let me tell you one thing, just skip the question, just answer me, Akshay, that is it possible that alveolar ventilation can be more than minute ventilation? Is it possible in any circumstance? Is it possible that alveolar ventilation is more than minute ventilation? Let me skip that question and then ask you this point. Is this possible? In any patient, normal, physiological, clinical, can alveolar ventilation more than minute? Yes, Pandya, I hope so. More and more you practice clinical MCQ, then only then you can be clear about the concept. Okay, now let me tell you. Okay, till now no one has given me correct option. Even no guess is wrong, right? But I believe that if you solve this question, generously, you are going to solve any question regarding that, about all those things. Okay, first of all, let me tell you, answer is B. So no one has even B. Okay, now let me discuss one by one. Please be focused. I want everyone to have gamma waves. Okay, and let me see. So in this scenario, okay, पहले बताओ what is minute ventilation? Yes, I am asking Oras and Akshay Gupta and Aditya and Preeti. Everyone, I am asking what is minute ventilation? I know it is a bit tough question, but you are tougher. I know you are tougher. So what is minute ventilation? Who will tell me? Please open your notes. Tidal volume into respiratory rate. And what is alveolar ventilation? What is alveolar ventilation, my dear friend? Good evening, Sharik. tidal volume minus dead space into respiratory rate. So first of all, tell me, is there any condition in which alveolar can be more than minute? Is there any condition in which alveolar can be more than minute ventilation? Yes, minute ventilation is the volume of gas inhaled or exhaled, total amount of gas. So of course, alveolar ventilation cannot be more than minute. So पहला तो अपने आप गलत हो गया ना. Alveolar ventilation, is there any situation in this alveolar ventilation exceed a minute ventilation? तो पहला तो absolutely rubbish, कुछ ऑप्शन ही गलत है पूरा. Even not about this question, of this option is wrong. Can anyone tell me? भाई कुछ तो dead space होगा ना. Alveolar ventilation will be of course always less than minute ventilation. Yes or no? Tell me, Akshay and Rav Verma. Is this point clear? Okay, now the third point, what is the dead space? What is the formula of dead space? It is tidal volume into, tell me, PaCO2 minus PeCO2 upon PaCO2. Is this a formula or not? So the third formula to remember here is dead space. And the fourth formula is dead space ventilation. If you know everything about everything, then only you can solve this MCQ. What is dead space ventilation? It is equal to dead space into respiratory rate. So this is the minimum requirement to understand that question, and I hope everyone should have this on the tip of the tongue. Okay, don't worry, Ravarma, I am on to you. I am watching you. You should know. Okay. So tell me, is this clear to everyone? Good. Okay, at least you all remember this. Very good. Auras, Ravarma, Sharik, Akshay, everyone good. Now coming back to the question. We have to compare normal with this patient. So coming to the normal values. So alveolar ventilation is given in the formula. It is frequency into tidal volume minus dead space. Where alveolar ventilation, all those things you know. So in a normal healthy adult, how much is the tidal volume? It is 500 ml. And the dead space is 150 ml. Yes or no? This everyone knows or not? And respiratory rate is approximately, you can say 12. You can say, okay. So what will be the normal alveolar ventilation? Just calculate. So if you want to calculate physiological alveolar ventilation, it is not minute ventilation, my dear. 500 minus how much is the dead space normally? 150, and respiratory rate is around 12. So how much it is? 350 into 12. So how much will is normal alveolar ventilation? Why you are saying 6 liter? 6 liter is, my dear friend, minute ventilation. If I am asking the minute ventilation normal, then you will say it is 6 liter tidal volume into respiratory rate. Don't get confused. Okay? So it is around how much? 4200 ml. 4200 ml. So this is your normal alveolar ventilation, and this is normal minute ventilation. I'm coming back to the question. So from now onward, if someone asks you, what is physiological minute ventilation, then your answer will be 6 liter. And if someone asks you what is physiological alveolar ventilation, then your answer should be 4200 ml. Okay, every time you don't have to solve that. You should remember this. If you remember, tidal volume is 500 ml, dead space is 150 ml, breath is 12 minutes per minute, so you should also remember this value. So this is about the normal physiological condition. Am I clear? Now in this scenario, when respiratory rate is high and tidal volume is low, so we need to calculate her physiological dead space by the given volume, and I have already given you the formula for that. Tidal volume into all those. Please, can anyone calculate for me what is dead space in this patient? In this patient, what is the dead space? Till now we have discussed about the normal physiological values. Now who is going to calculate for me what is dead space in this patient? I told you the formula. Okay, formula is tidal volume कितना है? How much it is? 480 into PaCO2. How much it is? 30 minus CO2 in the expired air. It is 18. This is 30, and if you solve it, come around 480 into 12, I think, upon 30, and it comes around 192. I am taking values from Akshay Komal, everyone. 18. So 192 is the dead space. So what will be the alveolar ventilation, my dear friend? So now calculate for me what is the alveolar ventilation in this particular patient. In this particular patient, it will be how much? 480 minus 192 into what is the respiratory rate? How much is the? Let me see how much it is. Okay, 30. No, कितना था? Yeah, 30. Yes, 30. It is 30 into 30. So what is the alveolar ventilation of this patient? Someone please do it for me. Okay, 8640 ml. And what is the normal alveolar ventilation? What is the normal in this patient? And what you have calculated in the normal alveolar ventilation? Tell me, कितना बताया था आपको? याद रखना हमेशा. You have to remember. I told you what is normal. Just now 4200 ml. 4200 ml is the normal. Okay, wonderful. It is the normal alveolar ventilation. So who is having more alveolar ventilation? The normal physiological condition or in this patient? What do you think? Tell me, alveolar ventilation is greater in this patient or normal? Alveolar ventilation is greater in this patient or normally? So you can see that alveolar ventilation is greater than the normal. Only after the calculation you can understand that. तुक्का मारने से नहीं होगा कि हाँ लग रहा है ये है, वो सांस ज़्यादा ले रही है, so it might be inadequate. Answer can be C. No, it is not inadequate. Is it inadequate? Is it so? Is it inadequate due to rapid breathing? No. Normal is only 4200, and this patient is having, 8640. It is not inadequate. It is even more than normal. So how you can say it is inadequate? So of course it is not inadequate. Alveolar ventilation is less than dead space. Now calculate dead space ventilation. How much will be the dead space ventilation? Dead space ventilation is equal to dead space which you have calculated at 192 into 30. कितना हो गया? 6 9 3 27 and 5 7 20, and it is 8640. No, it is not less than dead space. It is more than dead space. So it is more than dead space. I don't know really I should appreciate the doctors who are designing such a wonderful MCQ. Really, this is really a beautiful MCQ designed. It is testing almost everything. सब कुछ निकाल लेगा आपका, कुछ छोड़ेगा नहीं. Yes. So I hope there should be no doubt in now all of 4 options. I hope there should be no doubt in this 4 option to anyone. or any doubt, please ask me, because this is really wonderful question, and any question related to that can be solved only by, I mean, description of this question, because they have asked dead space ventilation, they have asked alveolar ventilation, they have asked minute ventilation, both in normal as well as in the patient. So you should also remember the normal values. Normally we have 4200 ml of alveolar ventilation, 6 liter of what, minute ventilation. Okay, okay, that's nice. So I think this is clear to everyone. So I hope from now onward, throughout your life, you should not follow, not forget, you should not forget these, I mean, 4 values. What is minute ventilation, what's alveolar ventilation, what is dead space, and what is dead space ventilation. Am I clear to everyone? Is this clear? Okay, you can revise after this. This will be recorded, so you can revise this session again, and you can note down this, please. Okay. So this is about this question. Okay, now next question, the otolith organs. This is a simple neat UG question. The otolith organs, the saccule and utricles are responsible for. Everyone might be knowing that. I shouldn't discuss this type of question because this is from NEET UG. You are, I mean, studying all those things. The otolith organs, the saccule, the utricles, these are responsible for what? Producing vestibulo-ocular reflex, detecting angular acceleration, detecting the position of head in the space, or producing stretch reflex. What should be the best option? This is of course your NEET UG question. Okay, before you, I mean, so Akshay Gupta, Sharik Imlan, Soumya Sri, Malakpalli, and Pradeep Kumar all are saying B. So Oris has changed his mind. Okay, okay. So now answers are coming C. Okay. So you can see that at least you should remember this point, that otolith organ, saccule and utricle are part of the vestibular apparatus. Let me zoom it, okay, a bit. Can it be zoomed? Okay. The otolith, the saccule, utricle are part of vestibular apparatus, and they are involved in detecting the orientation of head with respect to gravity. They contain small areas called macula, which are covered in gelatinous layer and have small calcium carbonate crystals, and these are called as statoconia. Their macula also contain thousands of hair cells, which contain 50 to 70 small cilia called stereocilia, and one large cilium called as kinocilium. This was we used to study in this NEET UG, isn't it? These hair cells are arranged in such a manner that their polarities cover all the direction, allowing them to detect the linear acceleration in any direction. So it is not angular; it is the linear acceleration. Can anyone tell me about angular acceleration? I want to take a full lecture on that. This is an important point. But I used to avoid because we are studying it from NEET UG, so I used to avoid those topics. Please tell me, please comment. तब तक मैं नेक्स्ट क्वेश्चन ओपन करता हूँ. 37-year-old, I mean pregnant women. A 37-year-old pregnant women mother has a reduction in the urinary striol excretion, okay, indicating vestibular lateral superior and posterior semicircular, okay, good, has a reduction in the urinary striol excretion indicating decline in the fetal adrenal cortical activity. Which of the following is the principal steroid secreted by fetal adrenal cortex? This was also asked in NEET PG 2020, I think, or 19. I don't remember, 20 or 19. It is a repeat question. What is the principal steroid? I will take a full lecture on the adrenal cortex. 1 hour lecture. I will try to launch a course on that in special class, in which I will discuss all those diseases like 21 hydroxylase deficiency, 11 deficiency, 18 deficiency. But today I will give you mnemonic. Okay, that much I do today only. Yes, very good, very good. Praful Gowda, Ravarma, very good. So everyone knows that principal steroid is DHEA, dihydroepiandrosterone. Okay, it is the principal steroid from where androgens and estrogens are formed. From where androgens, and ultimately it is converted into estrogen. This is quite simple question. Okay. Today I will not discuss, otherwise it will take 1 hour. So let me move to question. Otherwise I will take one class in which I will discuss all the diseases like 21 hydroxylase, 11 and all those. Take it. So you know about that. Okay, let me give a brief. There are 3 zones. You know that this is zona glomerulosa, this is zona fasciculata, this is zona reticularis. Okay, and this is about the salt hormone. That is your main hormone over here is aldosterone. And this is what? Cortisol. And reticularis is what? DHEA, dihydroepiandrosterone. And Ravarma has given one mnemonic. I forget that mnemonic. Ravarma will. You tell me the mnemonic. How to remember that? Yes, Ravarma. Why you have retracted your message? Please give me the mnemonic. Your favorite mnemonic. This is salt hormone. This is sugar hormone. And this is sex hormone. And Ravarma always, I don't know from where he get this point. I don't know his own personal experience. Okay. So it is copyright of Ravarma that more, what just tell me, more deeper, more sweeter. Okay. So according to Ravarma, more you go deeper, more it becomes sweeter. Okay. Salt, sugar and sex. Salt, sugar and sex. Aldosterone, cortisol and dihydroepiandrosterone. And for that you have a lot of enzymes. But today I will give you, 3 mnemonic. Just 3 mnemonic. 21 hydroxylase and 11 hydroxylase and 17 hydroxylase. A very basic simple mnemonic to remember all those diseases. If it is deficiency of 21 hydroxylase, if it is deficiency of 11 hydroxylase, or it is 17. Okay, the first word tell you about BP. And the second word tell you about Ravarma, is Ravarma, what is your favorite word? Androgen. Okay. Testosterone. Okay. So the first word tell you about BP, and second word will tell you about testosterone. Okay. So just remember that whenever you have one, it means it will increase. And if you have anything except 1, it is decrease. Like 2, 7, whatever be it. Okay. So BP. So when we talk about BP, so 2 means what? BP is less or high. I told you 1 means it is increase. And anything except 1, it means what? Tell me. So there will be hypotension or there will be hypertension? What do you think? Although I will take detailed lecture in this in a special class, if you have downloaded your Unacademy app, I will take a full class. So I told you if it is other than 2, it is less. So it means BP is less. So patient will be having hypotension, isn't it? So simple to understand. Believe me, you can solve all MCQ with the help of this three mnemonic. All the MCQ regarding adrenal cortex which are related to these diseases, okay, rest all is just extension of this mnemonic. So there will be hypotension and androgen will be high. So the patient will become Ravarma, androgen will become high. But if suppose that patient is female, now just imagine female Ravarma, this is very not good phenomena. It can cause virilization. In female, if androgen is high, it can cause virilization, isn't it? I mean male characteristics in female. It can cause facial hair. It can cause facial hair. Okay. It can cause clitoral enlargement. Okay. It can cause male pattern baldness. It can cause male pattern hair loss. Male pattern hair loss. Okay, not muscular body. There are changes there, of course, but they are mainly sexual changes. Virilization, facial hair. Yes, deep voice. Deep voice. Voice will be deep. I don't remember Ravarma has deep voice or not. I don't remember. I only see his comment. So, but of course, that female will be having all the features of Ravarma or any male. Any male. Hoarseness of voice. So, why there will be hoarseness of voice? Yes, Tara, we. Yes, deep voice will be there, of course. Okay, Binod, okay. So 11. Now coming to the second point, second mnemonic 11. 11 means your BP is high or low. If someone is having 11 hydroxylase deficiency, there is 121 hydroxylase deficiency, and if someone is having 11 hydroxylase deficiency, okay, then what will happen? BP will be more or less. Both is increased. One means so BP is more. So patient might be having hypertension. Okay, and of course androgens are also low. So 21 and 11, the main difference here is that 21 is hypotension variety and 11 is hypertension variety of the 21, and this is the most common. In the detailed lecture I will tell you there is a classical type, there is a partial type, so I will discuss in detail, but till now just remember this mnemonic. This mnemonic is going to help you a lot, believe me. Then there is 17 hydroxylase deficiency. Then there is 17 hydroxylase deficiency. Okay. So 1 means what? BP is high or low? 1 means BP is high. But what about 7? What about 7? It means androgen is low. Androgens are low. So you can see over here that if androgen is low, it cannot be issue in female, but it is really a issue in male. In male it can be a issue. Okay, if androgen is low, it can be a issue in male. Although this is a lesser variety, the most common variety is 21 hydroxylase deficiency. They are called as congenital adrenal hyperplasia because you will be having more and more ACTH, because your sexual hormones then they are varying, they are not in sync, so there will be a lot of ACTH, and you know that we have discussed this point that ACTH increase the size of adrenal cortex. So this is going to increase the size of adrenal cortex, and that can cause congenital adrenal hyperplasia. Okay, so I hope this mnemonic will help you. I hope this mnemonic is going to help you. And I always used, I forget to tell you that now Unacademy has bring a iconic subscription. I should tell you that also. This is a very good news for those who are preparing for PG. So now you are getting Prep Ladder as well as Unacademy live classes. So you are having benefit of both. I mean, recorded session of all the teachers and live classes of Unacademy. Okay, and you get the code from in description. You can get the code so that you can discount and all those things. So I hope this mnemonic is going to help a lot. After that, if you do MCQ, okay. So this is about this question. Although the question was not that important, but this discussion was very important for everyone. So now you should not forget this throughout your life. 21, 17, 11, all those things. Coming to the next question. Yes, Chinmay, can start PG preparation in first year. See, I mean to say one thing, that now PG preparation is not that you just repeat your. They are not going to give you repeated MCQ. Only if your concepts are good, then only you are going to get good seat. So believe me, if your concepts are good, so you will get definitely a seat. So you cannot say that PG preparation from first year. You can build your concept from first year itself. And I believe that these lectures, I think from Unacademy and Prep Ladder, are going to help you a lot. So there is a lot of discount also they are giving to us. Need a class on all special sense. Okay, I will try to take also that. Okay, so if you start preparing for your concept, because when I was in my first year, I was not that serious about the concept and all. So when I got to the second year, I was very much, I cannot understand pharmacology, I cannot understand pathology. So if your physiology is damn clear, it will help you understand your pathology, your pharmacology, your medicine. They are totally interlinked. It is like a base so that you can strengthen it from first year itself. And you are first year secondary student and you know a lot better than me. Because when I was in first year, I was not knowing all those things. Okay, so you all are getting better and better day by day, because competition is getting tougher and tougher day and day. So this is the only option. Okay. Now coming to the next question. 18-year-old adult, 18-year-old adult, young adult. Okay, 18 years से ज़्यादा हो गया तो adult हो गया. Okay, I can understand that. Complaints of increased somnolence during the daytime. दिन में बड़ी नींद आती है. Okay. Sudden periodic loss of muscle tone. Sudden periodic loss of muscle tone and excessive fatigue. Okay. Now he is diagnosed to have narcolepsy. So narcolepsy is associated with which of the following? Yes. Increased discharge of noradrenergic neurons in the locus ceruleus. Do you remember locus ceruleus? We discussed it in analgesic pathway. Do you remember this? Locus ceruleus. We have discussed this in analgesic pathway. Okay, anyway. Decreased adenosine level in reticular formation. So decreased adenosine will cause sleep or increase. Okay, let me discuss that. Now increased discharge of serotonergic neurons in midbrain raphe or destruction. Answer दिख गया. Destruction of orexin producing neuron in hypothalamic dysfunction. So आंसर तो दिख ही गया, लेकिन इससे पहले आपने आंसर दे दिया. That's good. Very good. So narcolepsy. Now tell me one thing. Narcolepsy is associated with REM sleep or NREM sleep. Tell me. In daytime sleepiness, is associated with REM or NREM. So we have already discussed this point, and you know all those things, that sleep sleep is of two types. You know about that. It is NREM as well as REM, non-rapid eye movement, and REM. So you know this. And narcolepsy is mainly associated with REM sleep. So daytime sleepiness Day, oh my God, daytime sleepiness is associated with the REM sleep. With the REM sleep. Normally, when you sleep, okay, tell me, normally in the night when you are sleeping, it starts from NREM or REM? You know, whenever we start sleep, it start with stage 1 of NREM, okay, then REM, then again NREM. There are 4-5 cycle like that, then again REM. But one characteristic is that when you proceed in the sleep, okay, NREM keep on decreasing, NREM keep on decreasing, and your REM will keep on increasing. So if you are sleeping for longer time, if you are sleeping for example 10 a.m., 11 a.m., okay, or 12 p.m., like that, if you are sleeping like that only, so you are really getting REM sleep or NREM sleep. Of course, you will be getting more of the REM sleep, isn't it? That is why early mornings are always good to wake up. Okay. Anyway, so narcolepsy is associated with REM, and you all know that what is the characteristic of REM. The characteristic of REM is loss of muscle tone. Loss of muscle tone. So all muscle will lose their tone except you know it, diaphragm as well as extraocular muscle, because आपको you have to do rapid eye movement. Or diaphragm क्यों? Because you have to live also, okay, you have to breathe also, otherwise you will be dead. Otherwise all muscle will lose the tone. And which is the first muscle which will lose its tone? It is cervical, yeah, or you can say neck muscle. That is why when you are in daytime sleepiness, you do like that, because your neck lose its tone, okay. And when you are sleeping, okay, adenosine is increased. Increase in adenosine causes sleep, not decrease. So this option is absolutely wrong. Decrease adenosine level in reticular formation, no. When ATP is energy, and when it is broken down into adenosine, you will sleep. ATP means energy level high, and when it is broken down into adenosine, it means you will sleep, isn't it? So increased discharge of noradrenergic neurons, no. Decrease adenosine level, no. It should be increased discharge of serotonergic neuron in mid-raphe nucleus. If you remember, these two are associated with what? Serotonergic mid-raphe nucleus from PAQ. These are associated with analgesic pathway. If you remember, we have discussed this point. We have already discussed in so much detail. Okay. So destruction of orexin producing neuron, this is of course going to cause a lot of sleep. So let me discuss that. It has been seen so many times that narcolepsy is associated with low level of orexin. It is associated with low level of orexin, okay, which is produced by neurons in the hypothalamus. So orexins, you know that they are increasing your appetite also, diet also. So if there is defective orexin receptor or destruction of orexin producing neurons, it can cause narcolepsy. So orexins are not only associated with increasing your hunger, but it is also associated with causing sleep. So narcolepsy is a sleep disorder where patient feel excessive sleepy during daytime and can fall asleep while working or talking. बात करते करते सो जाते हैं. Yes, Ravarma, there is your colleague. I don't remember the name. क्लास चल रही है, क्वेश्चन पूछते पूछते सो जाता है. Okay, he is asking question and he sleep also in between. I don't remember name. I should not name. Anyway, so they can also experience fatigue and cataplexy. What is cataplexy? Sudden loss of muscle tone, because this is associated with the REM sleep, so it will be associated with also cataplexy. Cataplexy can also be so severe as to cause paralysis during the attack. It is so severe it can I don't know बीच में मैं अगले something happened to my throat. Okay, cataplexy can be so severe that it can cause paralysis during the attack. It is called as sleep paralysis. आपकी आँख खुल गई, आपकी नींद खुल गई, but you cannot wake up. So patient can come to your clinic कि सर ऐसा ऐसा होता है. Okay, it is called as sleep paralysis. It is associated with the REM sleep. It is associated with the REM sleep. Serotonin suppress the sleep and adenosine induce the sleep. Please remember this. Okay, when you are happy, बड़े खुश होते हो, ठीक है, जियो to जियो free, and you have a phone. So anyway, you are very happy and you are engaged with that, and you are keep on talking like that. You are no sleep, 3 a.m., 4 a.m., 5 a.m. Okay, and Rav Verma will not come to morning class that day because he is so happy. He is not feeling sleep. He keep on talking because when you are happy. Okay, anyway, let me discuss other question. So now we know a lot of characteristics of Rav Verma. We can write an essay on him, isn't it? So one day whole world will know. Okay, a 87-year-old man was yes, accessorize a dog for narcolepsy. It can be given. Okay, I know everything. Okay, the 87-year-old man was admitted in the cardiac ICU with ascites, shortness of breath. No one, but Puru used to say that he used to call you whole night. Puru Verma. Okay, he might be telling lie, I don't know, but he used to say that. Okay, anyway, 87-year-old man was admitted in the cardiac ICU with ascites and shortness of breath and peripheral edema. After cardiac catheterization, the following values are obtained. Based on these values, what is her cardiac output? Now, applying the fixed formula for cardiac output, just calculate it. Applying fix. Okay. But I thought that he used to go to your place every day, and he does not join morning class because he is sleepy. I don't know what is the truth behind that. Okay, now calculate this. By using fix, I will give 30 seconds for that question. Yes, it's 30 seconds is over. Tell me the answer. It's very easy. You know the formula. What is formula of calculation of cardiac output? What is formula to calculate cardiac output? Oxygen consumption upon, yes, what is the formula to calculate cardiac output? Okay, nice. Some of you are telling me the answer. Good. So can you tell me the formula also so that everyone can be enlightened with you? By utilizing the Fick's principle, it is cardiac output upon, tell me, is equal to oxygen consumption. Yes. It is O2 pulmonary, and then this is in the artery, it is in the vein. It is in the vein. Okay. So you can put like that 280 upon Oxygen consumption is 280 ml per minute. It is equal to 280 ml per minute upon how much it is? 20 minus how much? 12. It come around 8. Okay, 8 3 is 24, 3.5. So 3.5 liter per minute. So these type of silly simple question come to your examination. So the best thing is that you should remember the formula. Cardiac output is equal to oxygen consumption upon oxygen in the artery minus oxygen in the vein. It is as simple as that. Okay, very good. So you know the formula, and after that let me do one more question. Okay, and then I will tomorrow again at same time 10 to 11. Okay, a 30-year-old man with severe epileptic condition with convulsions every few minutes along with the lapses of consciousness underwent experimental neurosurgery. Okay, the operation has a beneficial effect in relieving the seizure. Initially when there were no seizure drug, they used to do surgery of that. Do you know that? पहले पागलपन का इलाज क्या था? सिर्फ to cut that part of the brain which is disturbing you. But now you have excellent medication. So this is really a wonderful discovery that we are having a lot of antipsychotic drug, anti-seizure drug. Otherwise they used to cut the portion of the brain. Okay, but he has developed inability to long-term memory. So that was very, disaster. Although you can be treated from your depression and seizure, but you lost your memory formation. So it was worse than their life. He is although able to remember things from before his surgery. So this is retrograde amnesia or anterograde. It is retrograde amnesia or anterograde. He also displays a lack of fear while putting a shaving razor between his teeth. Shaving razor between the teeth. So there is no fear. So that person is completely fearless, like I must not name, just to see how it feels. So whenever he want to test something, he will put that in the mouth. He will do everything oral examination. He want to do oral examination of everything. Which of the following areas of brain would have been bilaterally resected in the patient? Yes, Sharik, retrograde amnesia. Why retrograde? He is able to remember the things before his surgery but cannot register the new memory. So anterograde or retrograde? What do you think about this? What do you think about this? Anterograde or retrograde? Please tell me. Okay, so you know anterograde. Okay, what is that syndrome called as? And it is because of which part of the brain? That part is not given here in the option. But that is the part of, this is the bigger version of that. But this question I have discussed in special class also. Also the amygdala is affected in the temporal lobe. Good, very good. So what is that called as? You are absolutely correct. But can you tell me what is this called as? What is this called as? Please tell me. Yes, Dr. Cool has answered. Very cool answer. So you know now that Kluver-Bucy syndrome. Okay, so the temporal lobe would have been bilaterally resected in this patient. In this scenario, what are the features of this syndrome? In this scenario, the patient exhibited lack of fear, loss of ability to form new memories. Okay, old memories will be there. So don't worry, Ravarma, all old memories will be there, but you cannot register new memory. Okay, so these signs point to the Kluver-Bucy syndrome. So a patient come to Dr. Ravarma and that he is complaining that I cannot form new memories and I don't have any fear. I also don't fear anyone, like that. So now Dr. Ravarma will make the diagnosis. Yes, you are having Kluver-Bucy syndrome. So you might be having bilateral ablation of amygdala. So now he is enlightened to make the diagnosis, and his pattern of memory is also suggestive of anterograde amnesia. Okay, so this is because of mainly amygdala, which is the part of temporal lobe, which is the part of temporal lobe. So I hope this much is clear till now. Any doubt? So this is it for today, and again I will tell you, if you like this video, please like this so that I can also get motivated from you people. Okay, I also need sometime motivation, not motivation, but it feels good that you are getting. If you like. If you don't like, you are free to unlike the video. Okay. And let me tell you the promo code which I have to tell. It is Dr. Naveen 10. Okay, there are so many subscription available in the Unacademy, especially the Iconic. In Iconic, you will be getting dual benefit of what Prep Ladder as well as your Unacademy live. So thanks for now. Okay, I will take. Thanks a lot, everyone. Thanks a lot, and thanks especially Dr. Ravarma that he don't mind my words. I used to bully a lot, but he's so kind for me, so that I can take his example, live example. So especially thanks to Dr. Ravarma for making things interesting. Okay. So thanks a lot. Otherwise things become boring, isn't it? Otherwise it become boring. Only fact, it will become boring. So Ravarma is the candidate. I can trust that he will not mind my words anytime. Okay, so thanks a lot. Thanks everyone for this class. Tomorrow 10 p.m. and also day after tomorrow. So in continuation we are going to have 3 classes. Okay. Thanks a lot. Which will be useful more to FMG student, Prep Ladder or Unacademy? See, I am telling you that Prep Ladder are having recorded video. They are excellent video, excellent educator. They are art teacher. They are, you can see they are excellent teacher. Okay. And Unacademy is also having almost all top India's teacher. Dr. Devesh, Dr. Nikita, Dr. Preeti, Dr. You can name every teacher is on the Unacademy platform. So, but problem is that if you do live classes, you interact. So all doubts can be clear. All doubts can be clear. So for that there is a new, now you know Prep Ladder is under Unacademy team. So if you take Iconic subscription, you will get recorded as well as Unacademy also. Because the best part is that this is the only platform in which we are taking the live classes. Every day we have to take. ऐसा नहीं कि एक बार record कर दिया फिर सो गए. Okay. Every day I have to study. I have to discuss with you all people. So that is the best part. It is the active involvement. Otherwise क्या होता है, recorded आप देख रहे हो, otherwise आपका WhatsApp आ गया, आप चलो कल पढ़ लेंगे. But you cannot postpone live classes, isn't it? The best thing is that. So thanks a lot. Thanks everyone. Thanks a lot.